So to build a sustainable and equitable precision oncology framework, stakeholders require both a compelling economic case as well as a clear understanding of health system readiness for routine genome-based testing. Our keynote presentation, Economic and Health System Readiness, Leveraging Evidence to Support Comprehensive Genomic Profiling Integration Across Canada, draws on two complementary bodies of work: the CGP costs and benefit analysis generated by Signal 49 Research in partnership with CRAN that Dr. Snow just spoke to, as well as the State of Readiness Progress Report 2.0, which examines the conditions required to support the routine use of genomic testing across Canada. We're very pleased to welcome Don Husereau, who's a health economist and adjunct professor at the University of Ottawa, and Eddie Nason, Director of Health at Signal 49 Research, for what I have absolutely no doubt will be both an insightful as well as an engaging presentation. Don will kick things off by providing insights into current system readiness, including progress and persistent challenges across jurisdictions. Then Eddie will present the economic evidence for CGP and its implications for real-world funding and system-level decision-making. These experts will then collectively identify practical opportunities to advance coordinated pan-Canadian CGP planning, implementation, and alignment across provinces and sectors. We'll hear what needs to be done and learn which stakeholders should be involved in execution. We should have a good amount of time dedicated to question and answer following the presentations, and I encourage our viewers to input your questions and comments using the bar below the live stream throughout the presentation, and we'll get to as many as we can afterwards. So a warm welcome to you both, Eddie and Don. And Don, we will turn it over to you to get started.
Thank you very much. And I thank you very much, and I thank Philomena and I thank CRAN for having me here today. And it's a real honor to sort of be invited with Eddie to do this keynote presentation. I'm going to share my slides. Here they are. There we go. As was mentioned, I'm Don Husereau. I'm a policy researcher, health economist, and have been doing work in the world of genomic and genetic testing, and not looking at any particular type of test, but really looking to see whether healthcare systems are ready to consider and adopt new testing, because as we often hear, particularly at these CRAN biomarker conferences, time is of the essence for patients, and so we don't have a lot of time, and we can't go through a lot of red tape if we want to consider and adopt new testing. Several years ago, we did an update. We did a State of Readiness progress report looking at how some of Canada's major provinces are ready to consider and adopt new testing. And in 2026, we released an update to that report, and I'm going to provide you information about the update. So just to let you know, I may have conflicts of interest, although I work both with private and publicly funded organizations. I formerly worked with Canada's Drug Agency. I have an HTA background, but I also served as a health economist, both on our National Oncology Drug Review Committee, but also in Ontario and Committee to Evaluate Drugs. And I'm a health policy researcher. Google me. I'm also a magician, so I put that in just in case you're wondering what the hell is going on. Overview, what is the issue? So the issue, this is what I'm going to talk about in this talk. Basically, what is the issue around genomic and genetic testing? What was the approach that I used to look at Canada's progress, and what did we find? And we can think about the issue of the need for genetic and genomic tests through a lens of the quadruple aim. You could also think of the quintuple aim, but we have here a technology that can be used in diagnosis, prognosis, treatment. It can predict who's going to do better, Of course, it's become a very major component of the cancer world, but it also is a major component of the infectious disease, public health surveillance world, of diagnosing rare disease and other applications. I'll get into that. So when I'm speaking about readiness, I don't think any particularly health system is simply going to be ready in one of those areas. They have to think about readiness across those areas. Why would we want to be ready for these new tests? Well, we're hearing about these things in cancer, so we could improve patient outcomes, for example, in ovarian cancer. People with BRCA mutations can have real advantages if they quickly have a BRCA mutation identified. Patient experiences, we know already that whole exome sequencing in infants who have suspected disease can save a whole bunch of diagnostic tests, and the diagnostic journey can be shortened considerably. We can actually lower costs of care, and that's been shown in the real world. Again, particularly in congenital disease of suspected congenital disease of infants, but in other areas as well. And then we also have to think about provider experiences, and Stephanie Snow certainly, I think, just described provider experience and the need for this, but certainly shoring up time is not only good for patients, but can help care providers as well. And testing is an interesting technology. Unlike a lot of technologies like vaccines or drugs or medical devices that are not in the realm of this genetic and genomic testing, testing can actually serve to help us understand disease better. It can be a source of, it is a new source of driving startup companies and the like. And in my report, and I'll give you a link to this in a bit, we describe several of these initiatives that have come out across Canada, and more to come. But one of the points I'm trying to make in the report as well is genomic testing is just the tip of the iceberg. Yes, we need to be ready for these types of tests, but there are people in Canada already looking into many other kinds of tests that don't just simply focus on genetic material or the product of genetic material, but look at a whole range of other things: proteomics, transcriptomics, metabolomics, looking at patterns of human metabolism that are personal to the individual as a way of providing highly, highly personalized care. And, through large scale processing, artificial intelligence and the like, we're going to be able to really make sense, I suspect, in the future in a more rapid fashion, take a lot of information from an individual using testing of some kind, so that we can highly personalize care, or we can predict how they're going to do on something, or we can give them a more accurate prognosis and the like. And also, as I just pointed out, genomic genetic testing is used for diagnosis and screening of rare disease. In oncology, its applications continue to expand, including comprehensive genomic profiling, but also plasma-based or liquid-based biopsy, primary cancers of unknown origin, the tumor-agnostic types of things. And beyond oncology, it's going into other areas, including rheumatology, organ transplantation, neurology, psychiatry. These are things that are already here in a sense, or just around the corner. So we have to be ready for this, not just because we want to do better by cancer patients, which I know is the very important focus of this meeting, but we also want to do better by other patients who are suffering from other diseases. So Why did we do a progress report? Well, we kind of wanted to motivate change. That was the point. Don't really want to write reports that don't have some kind of impact. So the idea was to communicate what are the gaps, what's the quality of systems in place to consider and adopt new technology, and what are some opportunities, and then provide some future direction. And we do believe it had an impact, and I'll get into that. So the approach that we took to look at progress was essentially we created and validated a list of conditions that we said, if you are ready to consider and adopt new testing, you should have the following conditions in place. And these conditions spanned, I think I have it in the next slide. Yes, they span, I'll get into it, but they span a whole bunch of healthcare system functions, spanning from finance to how you operationalize and assess things, et cetera. I'll get into that. So we took that list, we went across the country and said, and we talked to people on the ground and said, how are, do you have these things in place? How are you doing? And mapped it on to the list. And we developed this progress report. We essentially counted how many conditions were in place. Sometimes people had a condition completely established. Sometimes they had it partially established, but they were working on it. Sometimes they hadn't gotten to it yet. And we've been communicating this information. So if you're curious about the conditions, well, the conditions were developed as an intent to think about the kinds of things in the health system you don't want. So if you're not ready or considering and adopting new testing, you're going to end up with inconsistent care delivery, or something that's unsustainable, or duplication of testing, or low value care. And that's not what you want. You want something that's highly coordinated, highly functioning. So we created a list of conditions that stemmed across three buckets. One we call the infrastructure bucket. We said to appropriately deliver testing, you do have to have communities of practice. You have to make sure that the left hand is talking to the right hand, both in terms of people who are delivering care, but also people who are involved with the development and consideration of anyone who's involved with the consideration and adoption of testing, even involving more broadly engaging with IT people, innovators, and the like. You have to have a resource planning function because testing is here and it's going to expand. Important to and you need to have specialized resources like healthcare technologists and the like. You do need to, testing is not just testing, it's highly information technology dependent. You need that in place. You need systems to evaluate new proposals. You need a single entry point to evaluate proposals. You need coordinated service models, and you need tools for awareness and care navigation. So we call these operational conditions. And then finally, you need some additional conditions, including an appropriate financing approach. You need, these tests also need education and training, and of course, regulation, data privacy. And we also looked at the, testing is not something you can adopt from one day to the next. It takes months and months. So you also need to think about innovation and integrate that into your care pathways. So what did we find? Well, I told you we did the report in 2023 and then went to 2026. In 2023, I only picked 5 provinces nominally because they're the largest provinces, and also Nova Scotia is representative in the East. We gave them a grade based on the number and quality of the conditions that they had in place. Alberta was really quite organized. Alberta Precision Laboratories, a large laboratory service that coordinates across the province, and they had a lot of the necessary components. Ontario was just developing a whole system, and you can see by 2026 that system had been implemented. So they went from not having a lot of stuff in place to having a lot in place. Quebec has also been highly organized for years in terms of consideration and adoption of new tests. And B.C. They're quite aware of some of the gaps they have, but some of these things are very structural and have to do with how the healthcare system operates. B.C. has a regionalized system, and that creates some of the challenges that they've seen. If you wanted to think about the number of conditions, this is how it pans out. You can see the number of established conditions indicated by the dark color, partially established conditions indicated by the lighter shade, and then situations where the conditions have not been established at all. So we call that needs improvement. And so this is the sort of pattern across provinces. And we did ultimately give a grade, but the good news story here is that we found, the band of grades is pretty narrow now. I mean, I told you in 2023 we went from a B+ to a D. Well, now we're everybody's in this range of C to B+. So, and of course, there's a lot of awareness by provinces that they need to be ready to consider and adopt. And so in some cases, like in B.C., they continue to work on this challenge, and and even since the report have launched new initiatives. So I suspect well, everybody will be somewhere closer to an A sometime in the future. As I said, we released the reports this way. The 2023 report, you can find it by scanning the QR code. It's also actually on the internet under a website access to genomictesting.ca. We did have a peer-reviewed article in Current Oncology, and if you'd like, you can access that by scanning the QR code. This in 2026, we released the update. The update can be found on the Resilient Healthcare Coalition website under their partner projects, but there's also a QR code scan, and I think these slides are available to people after this conference if you'd like to do that as well. And we have just recently, just in time for this meeting, released the peer-reviewed report as well. And I have to say, CRAN was also fundamental in participating, and Philomena is a co-author on our report, and really helping the report along by describing the impact of not being ready to patients. So to summarize, the progress report shows that we're kind of moving closer to a state of readiness, but we're by no means completely ready. Different provinces have a different, every province has a responsibility for the laboratory function. So different provinces are moving it. They're using different approaches, different rates. But I think most provinces are well aware that, this is something that's not going to go away. They have to be ready to consider and adopt new testing. And I think this speaks to broader challenges of being ready to respond to anything disruptive. We have new disruptive technologies coming all the time, cell therapies, T-cell redirecting therapies, bispecifics, that require special infrastructure, special care pathways, special delivery. And, it's always too early until it's too late. These things, changing the way a healthcare system functions is a slow moving task. And so you really do have to be looking to the future and anticipate. And I think, as the CRAN's recent CGP report shows us, sometimes we know a technology might be valuable, but it's not enough. We do need to be actually responsive. Knowing that a technology might deliver something, okay, but now we need systems in place to actually take up technology and deliver. I should say also, when we looked at the readiness, in all cases, we're looking at the readiness to consider and adopt new testing. We didn't look at the quality of implementing new testing and how things are executed in practice. So things like turnaround times and the like. Obviously, that's a very important thing to patients and a very important aspect of quality. baby steps. We just wanted to, the bigger issue was, are you even ready to consider an adopt? And that's what this report is focused on. I'll stop there.
Thank you so
Right.
much, Don. Yeah, Eddie, over to you.
Yeah, thank you, Don. And Don condensing a huge amount of work into a very small space of time there. I will just share my slides. Okay, so hopefully this is now showing you the slide view. I want to
Eddie, sorry to interrupt you. You've just swapped into.
I swapped it the wrong way. Oh,
Yeah.
okay. Let me just fix that. Okay, hopefully that's now functioning.
Yes.
Perfect. Okay. So I want to sort of follow on from what Don talked about, but also expand a little on the things that I talked about last year around this, to really go from, if you were trying to understand what the value is of comprehensive genomic profiling, how would you understand it? To, okay, well, now we've got a better understanding. What does that mean for us? How does that align with the things that Don has talked about? I want to start off by giving a little bit of information about my organization. So Signal 49 is a long-established organization across Canada. Been doing a lot of work in this area, looking at how you build an understanding, particularly of the economic impacts of issues in public policy and in healthcare more broadly as well. So one of the areas that we work in a lot. This isn't just my work, so I want to acknowledge the rest of the team that have been involved, particularly the work of Chris Viel, who did a lot of work in building this this modeling approach. And just a bit of background on me. My background is a combination of genomics. I have an academic background in genomics, as well as work with Genome Canada, as well as work on understanding the impact of research and innovation across systems. So highly aligned with the kinds of things that I'm hoping to talk to you about. So I think one of the things that I wanted to say was that Don did great work in 2023, where he kind of highlighted, he and his team highlighted what there was significant interest and in people moving forward with comprehensive genomic profiling. So there were lots of reasons to be ready, but how do you move from that idea of we've got interest in making it happen to actually making it happen? And so that was something where we really need to understand, okay, what are the plans, what's the evidence, what are the approaches that you might need in order to actually move people to an idea that this is a smart move for your provincial health system, not just that it's valid and it's useful and it might be good for you, but actually it's the smart thing to do. And so that was really where this stemmed from. And so in order to be able to help people get to that point of why is this the smart move, we had to have some starting points. One of those things was, okay, well, where do we start? Well, let's start with something that's a really fast burning platform, really though, to show there's significant need and we need to do something about it. And so we talked about the idea of metastatic cancer. This is an area where obviously people have limited choices, limited options, significant challenges for patients in terms of outcomes, and particular interest in wanting to move to better approaches for metastatic cancer. So the second thing was, okay, well, considering that, how do we get a buy-in to the idea that CGP is important? Okay, well, let's talk about comprehensive genomic profiling as this is a precision tool aligned with precision treatment. So we want to be able to do things for people with metastatic cancer diagnoses that actually allows an alignment with the kind of things that might support their recovery or their prolongation of their life. And then building on the incredible work that CRAN has been able to do over the last few years, really listening for direction and understanding how does this align with patient needs, patient wants, patient expectations. This is something that we wanted to make sure really fits with how you think about this is the right thing for those people who are dealt a cancer diagnosis. This is the right approach that really meets their needs. So based on those, we really wanted to talk about, okay, well, if we are going to do something, how do we create a system change? How would we talk about the thing that Don mentioned, which is being impactful? And that is really a case of you need to find the right kinds of mechanics. Who are the people who are going to help you change the system? You need to provide them with the right tools. So as Don has already identified, there's a whole bunch of tools on the system readiness side. You need to provide them with the right tools in terms of how they think about whether they should use something or not. And then work out how do you get that team of mechanics to work together so that all of those things are able to be put in place and we can shift the system forwards. And so that's really the basis behind why we even thought about doing this and why this is an approach that might work. And so to do that, we had to go about thinking, okay, well, let's build this cost benefit modeling approach. And that consisted of essentially four characteristics. We need to identify what is the framework that we're looking at. How would we describe when CGP is in use and when it's not? And then how do we develop a model of what it would look like to shift to CGP versus a combination of CGP and other approaches, and then to place that into a Canadian context, an understanding that we have, as Don has identified, multiple systems across Canada, all of which are trying to do things in different ways, all of which might need different types of information, might not be ready to use things in different ways. And because we really wanted to be focused, we decided to say that, okay, well, this is actually going to be going down the route of let's start with 5 cancers. We'll look at 5 cancers that are highly significant as metastatic cancer diagnoses across Canada, and we will work out what does it look like when we try and build a model for those. The thing about modeling is it doesn't work if you don't have good data. So we wanted to make sure we had reliable data on what CGP actually costs, what are the benefits that are already existing in Canada, and that meant we needed to understand a little bit about what was actually going on in Canada already. It meant we couldn't jump to the idea of, okay, well, CGP in 5 years' time will look exactly like this. We had to start from a point where we had some data and then extrapolate outwards. So what we did was we built a model that looked at evidence on existing cost benefits for CGP. But just having an understanding of the existing cost benefits doesn't mean you don't have an idea of what might happen as we expect that cost benefit to increase. Genomics is a very fast-moving science. It's a very fast-moving technology, and it has gone basically ballistic over the last 10 to 15 years. And so we know that there is rapid growth and rapid adaptability and adoption of the capacity of this science to really deliver change for patients. And so we want to develop a modeling approach that identifies our extension of the current costs and benefits, where we understand that costs are likely to decrease, and we understand that benefits are likely to increase as CGP evolves over time. We know that tests get cheaper. We know that tests have more opportunities to identify biomarkers. So with that, we built a model that essentially has 5 characteristics. One is we wanted to look at a 5-year time horizon. So we'd start with our 2025 data, and then we would model that forwards to 2030. We had to be very specific about the incidence, and we were looking at stage 4 de novo diagnoses. We had to be specific about the type of tests we were looking at. So we identified 4 tests. I'm not going to go into details. There is a full report you can go and read that has full details of this, but 4 tests so that we could actually look at the specificity of those tests and how much the difference between cost and effectiveness looked like. And then an idea of biomarker prevalence. So in order to be able to model the value of CGP, we really need to understand what were these biomarkers, what was the prevalence and expected prevalence of them in each cancer type, and how were they being captured by those different CGP tests, and then align those with a patient pathway, which is how are patients being treated? What's the approach in terms of the treatments that they get? How does this align in terms of their testing to treatment approach? And so building that allows us to do a bit of an understanding of the costs associated with it. What does it cost to put in this CGP across the board? And And then what are the types of benefits that we might expect to see? So on the cost side, what we wanted to really include was, what's the current cost of CGP? We know that the bigger your panel, the more expensive they are. What are the additional resource requirements that go into those? And so building that into the testing costs. So we had an understanding of what's the staff, the technology, and those other approaches that are built into testing. We need to understand the treatment regimens so we could understand how it aligned with how people will be treated and what the difference was between alternative sequential testing and CGP use. One other really important component that we wanted to make sure we included was the idea of delay in treatment, because we know that there is a dollar value associated with delaying treatment. And so the longer you take between your diagnosis and being able to provide a treatment, the more expensive it becomes for the system. And then some costs, assuming we need to know that there are costs around rebiopsy and testing, because not every single biopsy is going to provide you with useful information for CGP. So understanding that we could build those in. So that's the cost side. And basically through the magic of modeling, we get to a point where we really wanted to understand that the costs here are actually lower than the standard of care for 3 of the 4 CGP panels that we actually looked at. And that this is compared to standard of care. And that's a big thing because that was across all 5 cancers. What it does was it identified that if you can reduce the time to testing, the time from testing to diagnosis and then treatment, you actually make a significant dent on the costs of the system. And so that can often outweigh the cost of the test itself, the diagnostic test. And with the one test that increased, more expensive test, more comprehensive, in terms of more biomarkers covered, that's already dropped in price in the time since we published the report and now. So if we were to run this again, we may even find that that test is now actually cost effective, lower cost than the current standard of care. So really, there is significant opportunity here to identify that when you want to make a wise decision about how you're spending your money in your system, this might be a wise decision because you're spending more in the current approach than you might be if you were able to shift over your metastatic cancers to this type of approach. So that's the cost side. So there's the opportunity there. There's also an opportunity in terms of the benefits. And the sorts of benefits we can talk about here are increased survival, some of the increased societal and economic contributions. So we have an idea about what it means if you survive longer, what your contribution is to the economic contribution. We have some other ideas around, there are other benefits that are around increased clinical trial enrollment and eligibility by going through the CGP process, the indication of therapy options in other tumor types, the ability to grow the value of CGP beyond a single test for a single tumor type. So really making this something that is valuable beyond that. So for our purposes, the focus of the modeling was really on the survival and the societal economic contribution. And in order to do that, again, I mentioned earlier, we need good data. There is not excellent data. There is not excellent data for all of these cancers. However, there is data in lung cancer that allows us to understand the difference between the benefits associated with CGP and the benefits associated with standard of care. That allows us to make some assumptions, admittedly heroic, but things that we are seeing come forward based on some of the early indications around the benefits, not necessarily comparatively between CGP and standard of care, but in terms of the benefits associated with CGP as its own approach. We see similar types of benefits across multiple cancers. And we use that as a proxy to basically say, well, we can give you an idea of what does it look like if you were to use CGP rather than standard of care in terms of the life years gained. How do we get an idea about what that looks like for each of these cancers using this proxy? And what we were able to identify is there is a significant life years gained benefit here over these 5 years. 3,440 life years gained for people diagnosed metastatic stage 4 cancer with these 5 cancers. That is a lot of people surviving longer, spending more time supporting their community, supporting their family, being able to engage, and having that life. I mean, it's a really important outcome. And because I work with a lot of economists, There's an opportunity here to look at what does that mean in terms of economic contributions. So understanding if you were to live longer, what does that mean in terms of the economic benefit you provide to Canada as a whole? And that comes out at over $180 million. And so again, we have an opportunity there to say, well, yes, okay, now you're getting an economic bump as well as the social bump and the life health bump. So really being able to say that we think there are lower costs, we think there are significant benefits. We've now made you a good reason why you might want to think about moving this forward. So if you have a system that is potentially ready, you can move it forwards. So building on Don's stuff, I want to talk a bit about how the system as a whole is ready, not just necessarily the systems in each province. But there has been a lot of buzz around CGP over the recent years. It was showcased by CDA's work in 2022 as something that can really work out. There is some uncertainty right now in cost effectiveness, but it's something where there's an opportunity. And Stephanie Snow, Dr. Snow mentioned earlier, liquid biopsy was identified in 2023 as part of the watch list of things that you should be looking at in terms of precision medicine methods. So this is a real opportunity. There's been work that's looked at cost effectiveness for multi-gene panels at very high thresholds, so $100,000 per life year gained. So there's work out there that's been looking at how you might get to cost effectiveness on this, and also how you might then adjust that in order to achieve that at lower thresholds. And within provinces themselves, Ontario, although they were behind in 2023, one of the things they had done is they actually did do a budget analysis of what lung cancer CGP might do. And so identified that if you had a 50% uptake, you would get moderate cost increases, but you would get a lot of benefit over the 3 years. So 680 life years gained just in cancer. And there's been work looking at distributed cost effectiveness analysis that suggests there's significant promise around this as an equity-based approach. So how do you actually use this to ensure that you get at groups that normally wouldn't be able to get at care? And from my perspective, the thing I'm really interested in here is, how do you go from evidence to decisions? How do you set the expectations for people with this kind of information to help move them forwards? Well, one thing is you want realistic economic evidence. People who are making these decisions have to understand that we have solid data that shows here's an investment we're making, and we have some sort of understanding with assumptions that we're going to get to a new place, even if we don't necessarily have the real world evidence on it right now. Understanding that this is one of the tools in decision making. Don's readiness work really showcases lots of the different factors that go into deciding whether your system is ready. That really is a parallel to all the decisions all the components that need to go into making a decision. But what we want to do is we want to help people manage uncertainty. We want to get to a point where we understand that people are engaging with that uncertainty in some sort of responsible way so that they're able to actually move it forwards. And so that leads me to the idea that really what we want to go from is modeling to real world. And Don mentioned this at the end as well, which is we really need an understanding of what does this look like in practice? Where is their therapy availability? Who's using it? How are they using it? What are the things that they're spending on it? What's the timelines they have? What's the scale and uptake? What is the workforce capacity to make that happen? So beyond the policies to the actual delivery. And then that allows you to then talk about what does jurisdictional alignment look like, whether that is within diverse systems where there are regional components like B.Sc, or whether that's in a single component like in Alberta, understanding how do those alignments fit together. And that's really how we want to move from this idea of we've got enough evidence from modeling that suggests you should make a sensible financial decision, sensible fiscal decision, to what does it mean when you put it into practice and you have the tools, the levers, the outcomes associated with it that move you into that. I will stop there. I will pass it back to Don, since I know that Don has a couple of other slides potentially to identify some of the things that really get to what does it mean to get at this change.
Okay, that's me.
Depending on the context.
Yeah, so I think, thank you, Eddie. So yeah, I think what we've been asked to do in this last bit is really, we wanted to put these things together. We have we have to identify practical opportunities to advance coordinated pan-Canadian CGP implementation. And as I said, CGP implementation is a very important application of genomic and genetic testing. So it starts with being ready for testing as a whole, but then it requires not just the component parts that I've highlighted in my report, but also it may require more. And Eddie's last slide sort of highlighted some of the things we actually have to think about, including capacity further, et cetera. So just as a starting point, in the progress report, opportunities to advance the consideration and adoption of new genome-based testing, thought about these components, and I talked about these resource planning and financing models, creating communities of care, information management, and the like. And these are all, again, intended to address certain issues that can come up with consideration, adoption, and implementation of testing. I think what we want to talk about is some of the challenges associated with these, and what are the opportunities. I don't know, Eddie, I guess, is it just me on screen?
We are
of us?
both on screen, but it's just your slides. But yeah, I
Okay.
mean, I think I would echo what you've said there, which is that we need to create an understanding of how you shift, right? I think we've given people some tools and ideas that this is a good thing to do. And it's now, how do we create the shift in systems or the shift in approach that allows people to actually keep moving from those B+ to C up to the A and B areas, particularly because we're seeing the implementation. And Don, I think, one of the things that you and I have talked about in the past is the idea here that understanding how someone else has done it, understanding the pitfalls or the opportunities that exist within that, is one of the really key measures and approaches that helps people who are in decision-making roles to look at something and go, actually, I'm able to do this. And so I think that's one of the things that I think is really high on that list of practical opportunities, is really building that understanding of what does it take to make this happen. So Don, I know there's things that come up from your readiness work that really focuses in there.
No, it's true. And then, and I think there's a corollary to that, which is sometimes we look at a jurisdiction, healthcare jurisdictions, and say, well, gee, they're not doing this here. Why don't they just copy what is being done over there? Well, it's not that easy. Different healthcare systems have different healthcare structures, different insurance structures, different delivery structures. So what we saw in the report is you can't apply sometimes, you can apply some of the lessons from some of the jurisdictions, but not all of them. I do think it is, in this day and age, possible to have, for example, this component, the evaluation function, some sort of assessment function, whether that be consideration of new things, and then monitoring how they work in the real world, or an HTA approach where you're actually trying to filter out what you think might be valuable for your system beforehand or after. I think HTA is fairly universal, and I think we do see, for example, in Alberta, they have a laboratory formulary committee. B.C. has a test committee. It's a similar type of approach, and I don't know why that wouldn't be sort of universally portable. And to the point of, why couldn't you do that in a pan-Canadian way? And I know that Canada Drug Agency is looking at working toward that. Why can't we just evaluate these things and have a common test review? But then there are things like, for example, your finance model. Certainly there might be things that you have to consider, how do you pay for laboratory tests? But different provinces pay for things differently. And so in Quebec, for example, we saw, there are provinces that have much more of a top-down approach. They're much more centralized. And then we see provinces where, you have much more powerful regional entities. And so can you apply one thing from one province to another? In some cases, very difficult. So I think as people looking in on this, we have to be practical. We can't say this province is doing it, why can't you? The other aspect of this too was scale. You know, Ontario was taking a lot of time to be ready, but Ontario is massive compared to other provinces. So, you know, whereas I saw Newfoundland was quite ready to consider and adopt new testing, but they're a very small province from a population perspective. So there's just many fewer moving parts in that.
Yeah.
And so it's sometimes easier to just get the necessary components in place.
And I think that's a really important point. I mean, I think one of the things we need to be able to do is to differentiate where there is pan-Canadian opportunity and where there isn't. But also to understand that we can bring contextual analysis to how people have managed to implement things. This has worked because this system is built this way, is a really important part of any kind of real world analysis, I think, is to then allow, okay, well, actually, if this is part of how your system functions, here's some of the things that might be appropriate for how you move it forwards. So you're not trying to recreate Alberta in an Ontario type scenario. You're not trying to be as small and nimble as Newfoundland might be if you are slow and deliberate. And then also to be able to learn from what works really well in each of those components. So if you are going to move things, if we need to move something small and nimble, then there are places where you can think, okay, that's a really good opportunity to actually try this new thing out. There are places where this might work. Let's have a think about how that really moves forward. If we need to work out, okay, well, how do we spread this across a large system? You have that in a different context conversation. And so I think there are some good opportunities for us as a community. That's researchers, decision makers, patient partners, organizations like CRAN, to really help drive a very nuanced conversation about we're not trying to impose a top-down structure on all of you. We're trying to allow this to work effectively for people across the country. And to do that, we understand there's nuance.
Yeah, I totally agree. And I like your, the idea of contextual analysis. You really have to, what type of healthcare system are you? Because there are healthcare systems, we have 10 different healthcare systems, and there are systems that are more like the UK's healthcare system or more like an American, Kaiser Permanente system, and there are systems that are less like that. And so we can phenotype those systems or look at contextualize them, as you say, we're better off. One of the things that also strikes me, and I think we'd all love to see patients being treated the same way, and we know of tests where there would be great advantages to doing them in a pan-Canadian way, because the test is so rarely used that to deliver a high quality service, you need high volumes. So that means you should just really do it out of one center. But we in Canada, unfortunately, and I don't know the way around this, structurally, we have challenges there. Every province has its own laboratory legislation. Every province has its own laboratory function. So coordinating across provinces becomes, even if you know it's a good idea, it becomes difficult for some aspects of what I'm talking about is delivery of testing. Yeah. But boy, wouldn't it be great if we could crack that nut and figure out a way to do that.
Yeah, and I think a big part of that is how do we engage those people who have some idea about what it looks like to work across jurisdictions. So groups like the Canadian Partnership Against Cancer, who have been talking about implementation in multiple jurisdictions, with a bit of that understanding about what works in one place doesn't necessarily work in another, but you might have some proof of concepts. Those are the sorts of things I think, we can find the right people, we can help to speak the right language, and organizations like CRAN are so vital in making sure that those conversations are completely above the idea that we're talking about an individual technology. We're actually talking about benefit to people. We're talking about the real world change for systems, and really driving people to an understanding that this is not advocacy in a traditional advocacy sense. This is advocacy in the sense that we think there's a good and a better way to do something, and we want to provide you with some ideas about whether that's right for you. And so I think those are some real opportunities that really build on that. And yeah, whether we can tag on to things like the Canadian Rare Disease Strategy, whether we can align with the way that research systems and research trials work as a pan-Canadian level, how we bring those into conversations. Those are some things that I think allow, maybe those are some tangents that allow us to bring some of that conversation into that pan-Canadian style approach.
And we really have to, because I can't recall if you look at this in your report, but CGP, for example, could be a fantastic idea. But now we're in a situation where, okay, but every province has to deliver this individually because of their laboratory legislation, because of their insurance structure. But is it really feasible to have CGP delivered individually by every single province? Do you get diminishing returns on volumes and things like that? Now you have a province like, now, of course, there are provinces that just refer to other provinces because they're so small, like PEI or the territories. But there are provinces that are just at the margin, that are just small enough that, yeah, we'd like to have that, but it's going to be difficult. So now it's about referral to other out of province centers. But now we run into the challenges of turnaround time and the like. And so we're going to have to find pan-Canadian solutions, it seems to me, as long as tests are complex and expensive and require like high service volumes to really be delivered.
Yeah, I agree. And that's one of the reasons why I think the contextual nature of good evidence of what people are doing right now really helps to move that needle forwards. Cassandra, I don't know if we have questions coming in.
Yeah, thank you. Thank you, Eddie and Dawn. If you want to just stop sharing there, Dawn, that would be perfect. So those were really great presentations on very, robust, impactful, and compelling bodies of work in the Canadian context. So thank you so much for summarizing them so nicely in such a short period of time. At this point, we do invite questions and comments from the audience, just again, using the questions bar below the video stream. But we'll get started with a couple. The first one here is for Dawn. And Dawn, how does your report factor in that different tumor types have different access to genomic testing? For example, testing that's being done in prostate cancer might be different from the testing being done in breast cancer within the same province.
I think my report's really looking more broadly at, are you ready to consider and adopt a test regardless of what cancer type? It's assuming that all cancer types are of equal importance, and that even cancer is, as important as diagnosing babies with rare conditions. So the report doesn't delve into sort of, or even speak to the virtues or the benefits of it or the cost effectiveness of any particular type of test. It just says you probably need a system in place to filter out what you think are good tests for your region. I mean, like even newborn screening, there are certain regions that, if we look at newborn screening, certain regions screen for a lot more than other regions. Well, if you're a very small region and you really have a very low prevalence of something, maybe there is no reason to sort of build that into a newborn screening program. So again, it becomes highly context dependent. But yeah, the report is agnostic about any particular type of cancer or any particular type of testing for any particular type of cancer.
Yeah.
Just says that we need to be ready for them.
Okay, thank you for that clarification. And healthcare, as we all know, is decentralized in Canada. So a question for both of you. Do you believe that there is value in establishing a standardized approach to CGP implementation throughout our country? Or perhaps would a scaled approach, starting with the provinces that have received those higher grades and are a little further along in their readiness, would that be more appropriate?
I'll go first on this one. I think we're already in a scaled approach by virtue of the fact that we have multiple systems across the country. So to some extent, that is a natural experiment that is happening, and we should probably understand it a bit better. Yes, there would be enormous value, as Don mentioned earlier, to being able to understand how to do this in areas where we think it's valuable in a pan-Canadian way. We want to drive equity, we want to drive outcomes, we want to drive impact for patients. where there's a real opportunity for that to happen in a pan-Canadian way, I think it would be great to do so. I think there are lots and lots of challenges as to why that might not happen very easily or very quickly, but I don't think that's a reason to not talk about it.
Okay, thank you, Eddie. Dawn, any reflections on that?
No, I mean, as I said, I think there are going to be certain areas where pan-Canadian approach is really needed. Obviously, we also want testing to adhere to a certain standard. I mean, the good news is that laboratories and laboratory leaders do have to adhere to certain standards in terms of what we call regulatory standards, but they have to adhere to certain quality standards. I mean, the profession of laboratory medicine is just very, very concerned with making sure they're, when they say you have a biomarker positive, that you are truly biomarker positive. They're very concerned with measurement and making sure that they're providing accurate and consistent measurements. So a lot of them use the same types of quality standards. But yeah, wouldn't it be great if we all knew we were getting exactly the same? I mean, even though those standards are in place, it doesn't mean necessarily that there could be some variation. And so, yeah, it might be better to have a single standard, or even just, again, a coordinated delivery so that we all know we're getting the same thing. But the pan-Canadian approach is always very difficult because, as I said, we work within legal frameworks where every province has its own system, and it's difficult to share. Even information, we've recently seen announcements about sharing health information across provinces. You need to, I mean, if you're going to do testing across provinces, you may need to share information about patients across provinces. And until recently, that wasn't even feasible.
Thank you. Thank you. And from the patient perspective, the importance of being able to access the same level of testing, regardless of your postal code or your province that you reside in, it's so important. It's such a big challenge to be able to ensure implementation readiness across provinces, but still allow for universality of healthcare as Canadians are entitled to from the Canada Health Act. Another question, Dawn, can you differentiate between the readiness that your report looks at, so the readiness for implementation, versus the readiness of delivery?
Yeah, I mean, again, as I said, we're looking at the readiness just to consider an adopt test, and it's nothing to like how ready you are or the quality of implementation and delivery. Matter of fact, I had feedback from people who said, hey, you said that this province was highly ready to consider an adopt test, but we happen to know that sometimes patients are really disenfranchised through long turnaround times or confusion with getting tests, et cetera, et cetera. The issue of like what's the quality of implementation or execution is it maybe even more tricky issue. I mean, first you have to come up with what are those quality metrics. It's easy just to say, well, turnaround time, that's definitely, well, okay, but that might be just one of many dimensions of quality in terms of execution and implementation of testing. So, I wish I would have had the remit to look at that, and maybe that is something that that's the next frontier, is really looking at that. I think to some extent, CRAN and Signal 49 are going to go ahead and look at that in maybe the sphere of CGP, but yeah, it's not some simple thing. I think there are many dimensions of quality of execution or delivery. We all have to decide, what's a minimal standard, and so by saying we all have to decide, that means, an informed community of experts has to decide what that is before we go and then sort of see how ready systems are, or to what degree they're delivering high quality care.
And I think that speaks to the idea that you're looking at a pathway here. It's not dissimilar to patient pathways through the process of getting care. You need to understand that you go through the idea of how do you build a system, and then how do you implement it, and then what are the outcomes, what are the integrations, what are the community contacts. And I think Don's work is an incredible necessary. It's not sufficient, but it is definitely necessary. And it's something that is a great starting point to really put provinces under the microscope on, are you doing things that set you up for success, even if you have not yet got to the point of understanding how you implement it effectively? Because you're not going to be able to implement effectively if you haven't built a system. And so I think it's a really necessary step.
Yeah, and I think both of these works really add to the mountain of evidence that's needed to compel change at the policy level. And it's not going to be one thing in particular, but adding to the evidence base. I think as well, we need to have, from the provincial level, we need to have the drive for change. We've recently seen some progress with Quebec funding CGP in some tumor types, and they received only a B- compared to some of the other provinces like Alberta and Newfoundland, who have seen higher grades on your report. So do you have any reflections as to what might compel a province to move forward, regardless of their kind of readiness level?
Can we do both? Like, I think we need the separate.
Well, again, it's highly contextual, as I said, like, you don't, testing is about looking for things. And you don't go looking for things if you don't think you're going to find them, or if you think the return on investment for finding those things is very, very low, you're going to look for things where you think they're actually going to be more impactful for your healthcare system. So, Alberta, smaller province than Quebec, different, may have different considerations, may have different priorities. Unfortunately, also, healthcare systems are highly influenced by election cycles, that kind of thing. So political mood shifts, and suddenly the emphasis on testing is maybe a lower priority or what have you. Quebec has consistently had testing as a sort of higher priority. They, engaged in a number of initiatives to sort of really try to make sure that they can consider and adopt new tests. And it may be that CGP comes out of systems for reasons that go beyond their readiness to consider and adopt. It can come from either the patients that they're treating, or the types of physicians that are treating, their training. There's a number of factors that go into what drives provinces to do this. Knowledge is not enough, as we know, and knowing something doesn't mean we do it. We have to we have warnings on packages of cigarettes that say smoking kills you. It doesn't stop people from smoking. So knowledge is only one component.
Yeah, and I want to come back to this idea of, that I put out there with ready, willing, and able. And we can show that people might be ready. We can potentially show that you might even be able. We could look at that implementation approach. The willingness component is a combination of lots of different factors that is driven by lots of different actors. And so, as Don mentioned, politics is part of it. But that means that people have a real role to play. Identifying that this is a priority in your province, that identifying this is something you think is worthwhile to move forwards. Creating some of that willingness is something that can be done in other ways. And I think understanding what it is that helps support the readiness, the willingness, and the ability to do it is something that helps you move the entire system forward to actually get you to those better outcomes.
So sometimes it's difficult for us to imagine, if we're advocates, either patients, if we're advocating for ourselves, or we're advocating for patients, or we see, industry advocates, and they're advocating for that thing. They say, I have this technology, or I'm a patient and I need this technology. And it's hard to imagine that when you're a cancer program, there's 100 things that people need, because there's 100 people like you coming across from different areas. And so, willingness is about what are the things that I'm I have 100 different priorities. Which one, bubbles up to the top? And as Eddie says, it's about people. It does, patient advocacy goes a long way, but there are other factors as well. So, I don't envy administrators and payers who have to juggle all of these different priorities, all of which can, meaningfully impact the lives of patients, but in different ways and different types of patients.
Thank you. And we'll wrap up in just a couple of minutes here. But before we do, Eddie, I wonder if you could just share a little bit of a sneak preview of what we're looking at in partnership for the second phase of our research. And I'll preface this by saying Philomena will be presenting briefly on this tomorrow. But for those watching right now, if you could just give us a little bit of insight into what's next, that would be great.
Sneak peek.
I'll try not to do it with too many spoilers for Philomena. In short, we talked about the idea that it would be great to know what it looks like in context when you were actually trying to do this. And there are ways that we think you can actually understand that by looking at places that have been trying to implement CGP and how they have managed to do that, where they've seen successes, a wide variety of different measures of what success looks like. As Don mentioned, it's not just about time from testing to treatment. There are lots of different capacities that you need to understand. And so building an idea of, okay, well, what would you really need to know that this is being put into practice well? How does that fit with the context in which it's happening? And how do we then share those lessons in a way that is effective for other people to be able to say, I can do something with this new knowledge? And so that's really where this next phase is looking at. And Philomena will do a far better job than I just did of describing the full thing. But yeah, exciting times, really interesting opportunity to help move the needle in a different way than perhaps the first piece did, and a different way than perhaps Don's work has done, to say, okay, well, this is a collective. All of these things come together. The reason Don and I are talking about this together, and we've worked together over the years on many different things, is so we understand that these different components need to fit together to make effective change. You can't just do it with one part. You end up needing multiple components. You need to be able to speak to multiple needs. So that's what the next phase is really trying to do.
Thank you so much, Eddie. That's a great wrap up. So I think that through these presentations and our keynote here, it's really been demonstrated that we're making progress in terms of readiness for implementation for a technology that has been demonstrated to save lives by extending life years and improve survival. And also save money and contribute to economic contribution. So these were two very compelling presentations. The data is there. It's there in the Canadian context. And my hope is that through the remainder of this conference, we can continue to address those implementation challenges and hopefully come up with some action-oriented calls to action to be able to bring forward to policymakers. So Eddie and Don, thank you very, very much for your not only your presentations today, but your continued engagement and partnership with CRAN. We really appreciate the opportunity to be able to work together.